Welcome everyone who's here and everyone who's logged on remotely. This is the AYA committee. I'm Becky Johnson, the chair, and we have a great lineup of speakers for you guys today. The overarching theme that I think you'll be seeing is collaboration. I'm amazed in the past couple of years how many protocols are jointly designed from the get-go, everything we always wanted, pediatrics and all of the NCT and adult groups working together on behalf of protocols that benefit AYAs. So we'll see a lot of those, and it's a pretty jam-packed schedule. So although we got started late due to technical issues, we're going to try to make it up and keep the speakers on time. Do you guys advance? It's this. All righty. Nope. Back. Okay. So we will hear first from our AYA community advocate, Lauren Freisel, about her booth that is here at the meeting. Then Brad Pollock about the AYA COVID vaccine study, which has had some modifications recently. An update on S1826 from Alex Herrera. An update from Itan Orgel on ACCL 1931, the levocarnitine prophylaxis study, which is now opened. Ibrahim Aldas has a new study, S2307, looking at a menin inhibitor in KMT2A rearranged ALL. And then Hallie Moore is going to talk about the GnRH agonist ovarian reserve study for AYAs with cancer. Boyu Hu will talk about AHOD 2131, the low-risk Hodgkin trial. I'll review the AYA PRO trial from the Alliance. Adam Duvall is talking about a sexuality study that we've discussed the protocol concept for here in previous years, and the Alliance is actually going to roll it out. Allison Rosen and Melissa Boschman from our committee will talk about their NCORP pilot grant study, which they introduced last time. And then we have a new AYA liaison to the breast committee, Erin Roche, who will talk about some of her current work at the Cleveland Clinic. And then we are going to end up with our guest speaker, Alicia Alvarez from UC Davis, who will discuss the global burden of AYA cancer with a focus on Latin America. The Latin America initiative had a full kind of mini symposium on AYA cancers last time, and so I'm hoping that this will lead to some collaborations in that area. So a couple of quick announcements. We're looking for new liaisons to the AYA committee from multiple disease committees. And so if you don't know of a AYA liaison from your particular area of interest, then please let me know, and your committee of origin, please let those chairs know. And we would love to get a broader distribution of liaisons from all the disease-specific committees that are relevant to AYA. Another quick announcement, remember that you can look for AYA trials in real time on the CTEP website. There is, under portfolios by disease, there's a specific AYA tab now, and that lists all of the open clinical trials. It's never too early to plan for a good meeting. The AYA Global Congress in 2024 will be in December in Melbourne, and so that should be great. And with that, I'd like to introduce Lauren Freisel, our AYA community advocate, an honorary doctorate.
Thank you. Hi, everyone. My name is Lauren Freisel. I'm a 12-year Hodgkin lymphoma survivor. I was 18 when I was diagnosed, as many of our Hodgkin patients are. And I am your adolescent young adult community advocate, meaning I serve as the patient voice for SWOG. So if you have a trial, you want to include the patient voice, you want to hear more about how to include the patient voice, absolutely reach out to myself or Allison Rosen, who's the research advocate. And we have other AYA advocates among our other committees as well that would be happy to help you and support you in your work. We are having a networking event with myself and our LGBTQ community advocate, Joelle Pointon. We are going to be doing this tomorrow. You are all invited free drinks. Come join us from 5 to 6:30 for a little happy hour up in the American Craft Lounge. So that is the restaurant right in the East Tower lobby. So very easy to find us. You're all invited. Please join us if you can. And that's my 2 cents.
Thank you, Lauren, and thank you to SWOG for this ongoing increasing visibility to AYAs. Next, we'll have updates and trials and development, starting with Dr. Pollack.
Thanks, Becky. And I'm sorry, can you guys hear me okay? Hopefully, yes?
Yeah.
Okay, good.
Yes.
I'm sorry I'm not there like I was last fall in person. Somebody has to hold the fort down here at UC Davis when our cancer center director is off gallivanting in Chicago. So welcome, everybody. Last year, I presented this study that we had opened. This was a vaccine study, a cohort study to look at the COVID vaccinations. And we had some difficulties accruing, even on the pure pediatric side, mainly because of some very restrictive eligibility. And one of those eligibility criterion were basically they had to be vaccine naive to go onto this cohort study. And we found that was a big block in a lot of institutions. So we just got an amendment through. I'm going to give you a little bit of an update, very briefly review what the study is, and then tell you about the amendment. Could I have the next slide, please, Becky? So why do the study? Well, it turns out that last year and the year before, there were limited data and guidelines for vaccination, and particularly in COVID-19 for patients undergoing cancer therapy. I just went onto the NCCN website minutes before this meeting just to see what was updated, and the updates were last year. So not much has been changed, added to, and the evidence base for what's going on with vaccination and cancer treatment still remains wide open. So the primary aim of this particular cohort study was to try to characterize the immunologic response following SARS-CoV-2 vaccination in children and adolescents. The upper age limit goes to 37 years of age. For those that are currently or who recently underwent cancer therapy. Next slide, please. So this study was activated in April of 22 last year. It is now open at 49 institutions. We've enrolled 73 so far. The target is 549, and that may get expanded upwards based on whether we can get good accrual or not. The first amendment we had was to actually extend the study to the adult groups. That happened in February. And then the second amendment, which we worked on, was really to expand the eligibility. So we have lifted the vaccine naive requirement. So patients that have been previously vaccinated up to 24 months before enrollment in the study are now allowed to be registered, and that's going to ease it a lot. A lot of, on the adult side, many adults were vaccinated. On the kids side, less so, but this turned out to be a big restriction. So now anybody who had previously been vaccinated, as long as it's within a 24-month window of when you're going to register on this protocol, is eligible. That's already having some positive effect now in the accrual in the last month or so. Next slide. Okay, so again, we now have 2 strata. We've opened this up to the folks that have previously been vaccinated, and we also have the vaccine naive folks. Next slide. Again, we're trying to characterize the response to the vaccine. Next slide. And we had a number of exploratory aims here, obviously to look at symptomatic infections that occur, and that's getting a little less interesting over time, given the fact that people seem to get reinfected. And of course, the issue isn't whether you're going to be infected or not, but whether you're going to have a serious course of a SARS-CoV-2 infection. I'm going to hear Anthony Fauci tonight in Sacramento because my medical school dean just got infected with COVID and she's home, so I'm getting her tickets. We're also going to be looking at the durability of the vaccine immune response over a 2-year period of time. We're going to try to describe some of the longer term impacts of the immune response. And there's a couple of biologic things we're going to be looking at as well in terms of immediate effects on serology and cell mediation. And importantly, we're also banking sera here, because again, as time goes on, the technology for doing much more accurate serology is getting better and better. So we know that as that advances, we want to be able to go back and look at some of these samples and look at these immunologic responses over time for patients. Next slide. So eligibility is anybody 6 months of age and older, up to actually 36 years of age at the time of enrollment. They have to be either have received or will receive an FDA-approved COVID-19 vaccine, have to have a confirmed cancer diagnosis, and they have to be treated at a North American site. So unfortunately, we weren't able to open this beyond the US and Canada, mainly because of logistics of getting the samples sent. We're doing this also with the SeroNet intramural program within the NCI. So this is kind of a joint effort. And of course, it has to be feasible to collect the specimens. Next slide. So that's really it. It's just an update of the study that we presented last year. This should be a no-brainer in terms of eligibility now. Also, I'd just say that we have quite a bit of experience with putting patients on the study. It's an observational study collecting blood samples over time. Not a lot of these things, but certainly when a vaccine dose has been administered, and then a kind of a follow-up one as well. And it turns out that if you happen to have a patient that received their first COVID vaccination, let's say 23 months ago, they're eligible to go in the study. And actually, they're going to be contributing one serial assessment, and then they would be off study on this one. I'm not saying you should stack the deck and trying to get a lot of previously vaccinated patients way back when, but it makes this even logistically easier. Please contact me, and I will go ahead and answer any questions you have or any issues that come up. But we really would like to get the accrual started now in the adult group. So thank you.
Thank you, Brad. Any questions? So previously vaccinated patients eligible up to 24 months after their vaccination and up to the age of 37. It should be great. Thank you. Thank you. Next speaker, Alex Herrera for S1826. Ah, well, that frees up our schedule a little. Hopefully he'll come on. Let's, Dr. Orgel, are you on? We could continue with Dr. Herrera when he gets here. Can you, can I advance it? The preview.
Everyone close their eyes.
There, let's see. He's going to be talking fast to present all these in 10 minutes. There we go. Boom. Dr. Orgel.
All right. Well, thank you, Becky, for the invitation to come and present. This is ACL 1931. It's a randomized trial of levocarantine prophylaxis to prevent liver toxicity in our AY patients receiving AL therapy. And don't go just yet. Back one. Well, on the previous slide, there we go. Just in the bottom, I just want to point out that this is being led by the SWOG, but it is open to all consortia, including SWOG. And so it's the first such trial to do so from a supportive care integrative approach. Next slide, please. So a brief bit of the rationale. We presented that I think 2 years ago, but grade 3 liver toxicity occurs in about 20% of AYA patients. Data has come out that not only does it interfere with chemotherapy delivery and causes patient morbidity, but it is also associated with poor survival. This was based on retrospective data in the United States, and most recently a report from the BFM group in over 1,000 patients showing that grade 3 liver toxicity was associated with poor EFS in their protocols as well. A brief note that as we all see clinically, obesity does exacerbate this risk. On our COG studies for both BALL and TALL, it was more than a 3-fold increase in the odds for developing hyperbilirubinemia in those patients with obesity. On the C1043 trial, as Anjali and many in this room probably showed, the BMI, as BMI increased, the rate of liver toxicity also increased to actually the highest BMI to being really common. And so in general, hyperbilirubinemia is common in AYA during AL induction, and patients with obesity are at increased risk. And I'm going to put a pin in that because we're going to come back to the obesity question later on. Next slide. So why levocarantine? So levocarantine is a key cofactor. It restores fatty acid transport into mitochondria of the liver, which is a very energy-hungry organ. It meets the energy needs. It helps restore the oxidative response and oxidative stress. And because of this, it's been used in many non-oncologic populations. Back, please. Is there seems like There's probably timing. I'll either have to talk faster or we're gonna have to go back. Thank you. And so there was a meta-analysis of over 1,000 patients showing that in all these non-oncology patients that liver carnitine actually reduced surrogate markers of liver toxicity. It was well tolerated, very mild side effects. And because of that, it's being now used off-label in many patients with ALL to prevent PEG hepatotoxicity. And so with this, there's been case studies published showing potential efficacy, but no strong randomized data which this trial will hopefully fill that knowledge gap. But because of that, it's already being used, it's in AY care pathways, it's making its way into recommendations. And so we need to address this knowledge gap to find out whether it is in fact efficacious or not. Next slide. To do so, we're conducting a one-to-one straightforward randomized trial, open label, liver carnitine prophylaxis versus no prophylaxis. Any patient who's receiving ALL therapy, we'll get to in a second, is eligible, including BT, lymphoblastic lymphoma, and MPAL. The dosing is that in the product insert, and what's been used most commonly across the case series, which is in the upper right, so 990 TID. The one key for this is that there is data showing that liver carnitine might work best before the dose of PEG, and so patients have to be enrolled before they get their first dose of PEG asparagase. But that can occur after they start other chemotherapy. So really, any time from the diagnosis up until that first dose of PEG is when they're eligible. And because of that tight window, the study includes a storage supply of tablets, which we'll get back to. But the bottom line is that as you activate the study, you can order your supply so you have it on hand for the patients once they enroll in the study. You don't have to wait for it to be shipped to the site. The one-to-one randomization, if you develop liver toxicity on arm A, where you're getting the carnitine, you can stay on study. If you're on arm B, there's an optional crossover to arm C where you can begin liver carnitine rescue. And those patients will have the option for staying on study in order to track outcomes for those who develop liver toxicity. Importantly, because we followed the product insert and met all the other requirements, this is an IND exempt trial from the FDA. Next slide. I think you skipped one. So the endpoint is conjugated hyperability greater than 3. This is the threshold for dose modifications of concurrent chemotherapy on the NCTN trials, both COG and C1043 and the newer trials. We will also be looking at AST and ALT elevations. And as I said, the hope is that this will not only decrease morbidity, but also improve our ability to deliver chemotherapy. And so we are going to be looking at disease response by MRD, either by NGS and or by flow, to see if we're actually improving disease response by delivering the optimal chemotherapy. There's a whole host of exploratory endpoints I won't go into, but there's just a few I do want to pick out. One is that this is not a randomized question for rescue, but we are keeping those patients on trials. So we will describe outcomes for those who stay on the rescue arm. We will be looking at other toxicities, pancreatitis, cardiac toxicity, neurotoxicity, because there is some data showing that liver carnitine may help with those as well. And as an AYA population, we know adherence can be challenging. And so we are going to ask for pill counts at the end of induction. This is a 1-month quick in, quick out trial, really try to minimize the burden as much as we could. But so it's only the one-time pill count at the very end and self-report weekly whether patients are taking the medicine. As a lot of data has come out from SWOG and other consortia that both racial and ethnic disparities are present in hepatotoxicity and also the confounding factors of BMI, age, and BSA, we are going to take this really nice, well-characterized cohort we're going to have to actually hopefully answer some of these questions in a more definitive way. Next slide. Eligibility. So the big highlighted box up top, you do not need to be on a frontline trial. It's not required. There are frontline trials you may be allowed to be co-enrolled in, most likely those who don't have an intervention induction, and that's an ongoing discussion within the NCTN groups for the trials that are open or soon to be reopening. The age is our standard, currently standard anyway, 15 to 39 years, not down to 12, but starting at 15. Again, any diagnosis that's receiving an ALL induction regimen is eligible. So lymphoma, ALL, MPAL, particularly relevant for this audience. Ph positive and Ph-like are both eligible as well, and we'll be tracking TKI use in this group. They have to be getting a 4-drug induction, so a C1043-based induction regimen or COG or BFM. They can be getting either CalPEG or PEG asparagase. Again, in this group, will most likely be the latter. And the dose, because it does vary amongst consortia, both on protocol and off, has to be at least 1,000 units per meter squared, and dose capping is permitted. A quick point on the eligibility is organ function. This is a prevention trial to prevent liver toxicity. So we are looking for healthy livers at the start of this, but that does not have to be a diagnosis. So patients can come in with leukemia involvement in the liver, start on steroids, get cleared out, As long as the liver goes back to relative normal before we start enrollment, then you're okay to be enrolled in the trial. The other key part, and this is from the FDA in order to be FDA exempt for the drug ID exempt, you have to start the trial on PO levocarnitine. So even though we have IV formulation available, per the FDA, which we will not get into, you need to start on PO levocarnitine. Once you're enrolled, once you're on after the first dose, then the IV is available if you need to substitute for some reason. And their patients cannot have pre-existing known liver fibrosis. You don't have to go biopsying or searching, or known conjugated bilirubin disorders going into therapy. Next slide. Very briefly on the neurotoxicity, we are using the AYA-friendly FACT, GOG, and TX, so the very brief neurotoxicity measure. It's only 2 time points. It's at baseline, in that anytime in that first week before the second dose of vincristine, and at the end of induction. Patients need to be asked if they will complete it, but they don't, but it's optional. They can say no and still stay on study. This came up already as some of the questions from sites. And it's also a central capture. So there's a contact form that's included in the documents. Once it's filled out, the study team itself is going to reach out to have them completed in REDCap and electronic data capture. If for some reason they don't want to do that, or the site doesn't want to do that, then there is a paper option as well. Next slide. Very exciting biology, at least to me anyway, currently is being banked as we're waiting for our final funding approval to come through. A lot of the data coming from the NCTN groups, including from SWOG itself, is looking at the pharmacogenomics of the hepatotoxicity. And so we are going to be looking at that on this trial. Dr. Lauchar will be looking at as the integrated biology lab for this. So we'll be looking at pharmacogenomics, looking at SSD2, PNLPA3. We'll also be doing more of a GWAS approach. On top of that, we're going to be looking at carnitine levels, both as a measure of how much do you need and as a measure of adherence as well. And as some of the mechanism, which is still being explored, looks at oxygen stress and mitochondria damage, I'm really excited to be looking at this with Huda, looking at the specific components. As I mentioned, we have preliminary approval for this. We're anticipating final approval this month, in which case we'll be having an amendment to go from a banking to an actual active biology piece of this. Next slide. We are looking to enroll 420 evaluable patients. Obviously, there's going to be some dropout for toxicity during induction. When the target goal we set was a 50% reduction in the rate of dose-limiting bilirubinemia. It's a stratified randomization. As I mentioned early on, we see very clearly across all the cohorts that obesity does increase the risk. So patients are being stratified by BMI. And though age does play a factor, we also recognize that the way this treatment plan is delivered between COG and the adult sites does vary on some of what we call the unknowable factors. And so we are stratifying by the NCTN group, the COG consortium versus the NCTN adult consortium. And this will hopefully also roughly control for age. But on top of that, we are going to account for age as a covariable in the final analyses. This is based mostly on case series from real world evidence. And so there is a futility and efficacy assessment as seen here. And now is the first NCTN-Y trial looking at all 4 consortia. We have an estimate for control arm rate that's based on rates from all the different groups, but we are also going to do a sample size re-estimation depending on what the control rate ends up being from the population overall. Next slide.
30 more seconds if you can.
Oh, I'm good. Study status, key points. It's open. It's on, a question came up, it's on the CTSU website. We're already enrolling, but please take a look for it and open if you can. Next slide. Quick reminders, it's on the menu. You do not need to be in a frontline trial. It's under discussion whether you can be. Order the tablets on activation, not on enrollment. And then we are going to be looking for the amendment forthcoming to open it, but it's currently being banked at Nationwide. And last reminder, the study is open. Please, please, please consider opening it at your sites. It's a very low burden trial in the sense that it's only a month long. And so we are hopeful that we'll be able to answer this question quickly. Last slide, Becky. So thank you to everyone. So thank you to Lydian for sponsoring the trial, of course. Thank you to all the COG folks, but really, really thank you to our NCTN champions, Andre, Lori, Wendy, Nicole, and Selena, Huda, who early input from them as well as on NCTN AOL calls was instrumental in getting this off the ground and really launching. So we are now active, really excited to have this first type of trial up and running. And my email is here in the bottom. I am out of time, even though I spoke fast. So any questions, suggestions, please, please feel free to reach out.
Thank you so much, Itan. Exciting that it's open. All right. Do we have Dr. Aldas on the line?
I am, yes, I'm here.
Great.
So I'll be presenting on menin inhibitor study in combination with frontline chemotherapy and blinatumomab in KMT2 to rearrange ALL and acute leukemia with ambiguous lineage on behalf of the NCTCN and the SWOG. So we can move to the next slide, please. So although KMT2 arrangement is not very common genetic finding, I mean, it's the main genetic finding in infant ALL, but after that, the incidence is around 5% in children, but increase in adulthood and reach 15%. We see it more frequently. Do you want to move to the next slide, please? More frequently, we see it in therapy-related ALL, but it also can be seen up to 10% of acute leukemia with ambiguous lineage. Next slide, please. So although it's not uncommon, it is associated with poor outcomes with standard frontline chemotherapy, and this is different kind of studies. The first one on the left from MD Anderson that shows the poor outcomes of this entity, including patients who went to transplant to achieve MRD negativity early on. And then the middle one, this is actually post-hoc molecular analysis of patients enrolled on the ECOG 2993. And you can see actually the KMT2A rearranged cases. I mean, they have one of the worst survival outcomes. And on the right, this is data from children. Although their outcomes better than adults with KMT2A rearrangement, still the risk of relapse is higher than what is encountered in other subtypes of B cells. And you can see in the table that MRD post-induction is 37% with a definition of 0.05% or more. So this patient tend to have more MRD positivity post-induction and high risk of relapse. Next slide. And this is a more recent actually publication from France that shows that the incidence of KMT2 arrangement in B-cell ALL was as high as 13%. And what predict the outcomes of these patients is the concurrent TP53 mutation and IKZF1 alteration. And also early MRD positivity. Patients with early MRD positivity, they have more than 60% risk of relapse when treated with chemotherapy. Next slide, please. So KMT2 arranged ALL is an area of unmet therapeutic need because outcomes remain unsatisfactory with frontline chemotherapy. Even with transplant, the risk of relapse is high. And they tend to can undergo lineage switch to myeloid phenotype more frequently when they get treated with CD19 targeted immune therapy. And the expression of CD22 is lower compared to other subtypes. So intuzumab may not be as active as other B-cell ALL. And for acute leukemia with ambiguous lineage, they have limited therapeutic options, and historically they have been excluded from clinical studies. Next slide. So revumenib, it's an oral potent menin inhibitor. It targets the MLL binding pocket of menin to disrupt the interaction between MLL and menin. And by displacing menin from chromatin complexes, it suppresses the expression of target genes like HOXA and MESA1. Next slide. A single agent in phase 1 study included both children and adults. Revumenib, or the Syndex 5613, was associated with low frequency of grade 3 or more treatment-related adverse events. The main one was reversible QTc prolongation, but there was no ventricular arrhythmia and almost always reversible. Now, it's a differentiating agent, so differentiation syndrome has been seen with menin inhibitors, and in the phase 1 study, the rate was 16%. There was no grade 3 differentiation syndrome, at least in the phase 1 study. And it is safe, it is given orally, and it is effective as single agent. You can see that the overall response rate in patient, next slide, please. In patient with both KMT2 arranged acute leukemia and patient with NPM1 mutated acute leukemia, relapse refractory was 53%. And if you focus on the KMT2 arranged acute leukemia, it was as high as 59%. Many of these responses were MRD negative, and on average take 2 months to achieve CR/CRh with single agent revumenib. Next slide, please. So here we hypothesize that the combination of revumenib with frontline age-guided chemo regimen in patients with newly diagnosed KMT2A ALL or ALL, or with blinatumomab in previously treated patients is safe and well tolerated and potentially will achieve higher MRD negative remission rate in newly diagnosed patients. Next slide. So this is a prospective multicenter phase 1b study looking mainly at safety and tolerability and try to identify the recommended phase 2 dosing for the combination therapy. We propose 4 independent cohorts. Cohort A and P in combination with frontline chemotherapy. A was designed for younger patients up to age 49 using AYA regimen, and cohort P was designed for older patients 50 and above using age-adjusted hyper-CVAD in combination with revumenib. Now, cohort C and D using revumenib in combination with blinatumomab in patients in CR1, either MRD positive or negative. The difference between the two cohorts that C for patient did not receive revumenib before during induction consolidation, and the patient who received it during induction consolidation, just to see if there is any cumulative toxicity. Now moving to the next slide. So the reason we're combining with blinatumomab, because most likely will be standard of care for patients in CR1 in adults based on the ECOG 1910 study that shows improved survival and relapse-free survival. But even the use of blinatumomab in children seems kind of it's in the way actually to be kind of more popular. There is a study that was published recently in infant with KMT2A ALL that shows actually early introduction of blinatumomab led to high MRD negative CR, and when they compare with historic control, it seems that the survival, overall survival, disease-free survival has improved by the early introduction of blinatumomab. Next slide. So this is the study design. Again, we're still discussing with NCI. Initially, we kind of proposed 3+3 design, but we may move to actually rolling 6. But each cohort will be kind of evaluated independently. And once we have the recommended phase 2 dosing, we'll add another 6 patients on the expansion cohort. And we have dose level -1, -2 as well. So this is the estimated sample size, but this may change as we have a meeting with the NCI this coming Monday. But the initial proposal was between 48 to 140 patients. Next slide, please. This is the proposed dose level where we're going to use the lower recommended phase 2 study in the phase 1 single agent revumenib, and we allow dose level -1 and -2. Next slide, please. So this is the study schema. So for newly diagnosed patients with KMT2A rearrangement, if they're younger, they receive 4 drugs induction, like similar to the C10403, similar to the SWOG induction regimens and consolidation. And the revumenib is given during induction and consolidation. If they're 50 and above or between 40 and 49, and the treating physician feels that the patient not eligible for AYA regimen, they receive revumenib with age-adjusted hyper-CVAD. And we have patients who has the KMT2 arrangement, CD19 positive acute leukemia, who didn't receive revumenib during induction consolidation, and they achieve CR, MRD positive or negative. They can receive it with blinatumomab on cohort C, and patients who actually treated on cohort A and B, they can receive it with blinatumomab in cohort D. So these are the objective is assess the safety of the combination in each cohort and establish the recommended phase 2 dosing, and also the safety of revumenib in combination with blinatumomab.
1 minute.
Okay, who received blinatumomab in CR1 among either revumenib naive or revumenib treated patient. And for secondary, we're looking to estimate the composite remission rate, the MRD response, and the MRD response in patients treated with blinatumomab and had prior MRD positive disease, as well as event-free survival and overall survival. And these are the eligibility criteria. Patient can have ALL or acute leukemia with ambiguous lineage, can be B cell or T cell, but they have to have the KMT2 arrangement documented locally. And standard adequate organ functions. One of the toxicities QTC prolongation. So having QTC more than 450 is an exclusion. Can you move please to the next ones? Sorry, next one. Next one. Okay, and one more, please. And this is the eligibility for cohort C and D patient receiving the blinatumomab in combination with revumenib. And again, I mean, standard eligibility criteria, QTC F has to be less than 450, and the plan is to give blinatumomab. Patient can be CR1 MRD positive or MRD negative. That's the last slide. Thank you.
Thank you so much. You study Dr. Moore next, and Dr. Herrera, if you're online now, we'll do your talk after Dr. Moore.
All right, I'm going to do my best to beat that buzzer. Thank you. So I'm going to share with you the SWOG-led ALT 2131 intergroup study of triptorelin for protection of ovarian reserve in AYAs with cancer. These are my disclosures. And so this, as some of the other studies we've heard about, is a consortium, while SWOG is leading and doing this statistics. SWOG, ECOG, Akron, and Alliance have all been heavily involved with the development of this trial. So the idea of using a GnRH agonist during chemotherapy to protect ovarian function is not new. There have been many studies looking at this. The majority and the largest have been in breast cancer, where this is now considered a standard treatment. However, for non-breast cancers, there's a lot more controversy and less robust data about the efficacy of this. So this study saw, and currently the guidelines from ASCO recommend this for breast cancer patients, but not for other types of malignancies. So this study is aimed to look at the impact of the GnRH analog triptorelin on ovarian reserve in non-breast AYA patients who are receiving alkylating agent chemotherapy. The study is going to look at AMH levels at 2 years post-cancer therapy between the two study arms as the primary endpoint. And then there's going to be a variety of secondary endpoints, including changes in AMH over time. The study is going to look at estrogen deprivation symptoms, menstrual patterns, and quality of life. And there's also evidence that certain genetic profiles that are at higher risk for loss of ovarian function with chemotherapy. And so that particular group is going to be studied as well. And then hopefully this will establish a unique cohort of young patients who received chemotherapy with or without a GnRH analog, and we can study the long-term reproductive health outcomes. So eligibility will be post-menarchal. So regardless of age, if they've been through if they're post-menarchal, they can be eligible up to age 39, so under the age of 40. And doesn't matter what type of cancer they have, they just can't have had breast cancer. And the planned treatment does need to include an alkylating agent, and the planned treatment should not be for more than 12 months. Non-alkylating agent longer-term maintenance therapies are allowed. And then there is a minimum planned dose of cyclophosphamide equivalent for the younger age group. And patients should not be planning to receive radiation to the pelvis or cranial radiation, which may also affect ovarian outcomes. They can't be pregnant or breastfeeding. Fertility preservation procedures are absolutely allowed and in fact encouraged. So it's a multi-site intergroup randomized controlled trial. Participants will be stratified by age. The aim is to accrue 125 patients per study arm, and that's that accounts for even up to a 40% attrition over the course of the trial. The triptorelin should be given prior to initiation of cancer treatment. We're going to be very flexible on this. Other studies have looked at starting at a week or 2 weeks prior to chemotherapy. We do not want patients to not enroll because of not wanting to delay chemotherapy. So if they can't get it a week before, if they can even get it on the same day of their first chemotherapy dose, because presumably they will have the protective effect for ongoing dosing. 4 time points will be assessed: initial enrollment, end of treatment at 1 year, and 2 years post-treatment. And again, we're going to be looking primarily at AMH levels, but also at other hormone levels, menstrual history, symptoms, quality of life, and reproductive outcomes. This is some of the patient-reported outcome instruments that are going to be used. So a lot focusing on estrogen deprivation symptoms, sexual health, and reproductive outcomes. So it's a 2-phase process. So we'll start with a pilot of 50 to 60 patients, and then assuming it is feasible, we'll move into the full trial. And actually, I need to update this slide, but we did receive funding from the DoD for the pilot phase of the trial. So we can call that confirmed. So that's great. So right now the protocol is nearly fully written, is being finalized. And so we expect this study to be opening within, hopefully prior to the next meeting here, but within the upcoming months. And again, this is just the sample size considerations for the full trial. And I don't know where I'm pointing this. In the air. We anticipate that the trial will include patients with sarcoma, lymphoma, and ALL, but again, other malignancies are permitted. And then this is just estimates of the number of patients that we see. And so the NCTN sees about 6,000 AYA female patients with diseases that might fit into the study, and about 3,000 total from SWOG. So hopefully you will all be interested in putting patients on this study. There's a question mark on the second bullet point. There actually will be protocol suggested alternatives for menstrual suppression for patients with thrombocytopenia and heavy menses. And the real question is, will your groups accept randomization? Are people already doing this? Are you using GnRH agonists for menstrual suppression so that you wouldn't feel comfortable? We think it's a really important question. So would love any feedback, or I can answer or try to answer any questions you might have.
Questions for Dr. Moore? Would you guys use this for your patients? I think it's exciting that there will be a trial, and we've been using it in our clinic for years, but it's in the absence of data. And so with the fact that this would be open, I think many people would probably do it.
Great.
I hope so.
We'll
Yeah.
find out in that pilot phase.
It'd be nice to get this data. It's been a long time coming. It's a hard question to answer, right?
Yeah. Yep.
So,
So, all right. Thank you very much.
thank you so much. All right. Dr. Herrera, are you online now? Do you see him on? Let's see if I can see him. Nope. Okay. Okay. We'll proceed then with Dr. Hu. Low risk Hodgkin trial. Welcome.
Thanks. Thank you all for having me today. My name is Boyi Hu. I'm one of the lymphoma providers at the University of Utah, and also an active member of the lymphoma SWOG lymphoma committee. Also the AHA 2131 adult co-chair, which is a randomized phase 3 interim response adaptive trial comparing standard therapy with immuno-oncology therapy for children and adults with newly diagnosed stage 1 and 2 classical Hodgkin lymphoma. Here are my disclosures. As we all know, early stage Hodgkin lymphoma is highly curable, has excellent overall survivals of upwards of greater than 90% through the years. So here's an early trial looking at MOP-ABV plus radiation, showing overall survivals approaching about 90%. Even with our modern trials that have employed interim PET scans, escalation, de-escalation strategies, this overall survival curves have now flattened out and now approaches even 100%. And so Hodgkin lymphoma has really become the gold standard in terms of oncology and cancer treatments, in that when we're developing new treatments for Hodgkin lymphoma, we're not only trying to maintain the incredibly high cure rates, but now we're actually focusing our attention on the acute and long-term toxicities of both chemotherapy and also radiation therapy, which includes infection, infertility, secondary malignancies, and cardiac and pulmonary adverse events. And so right now in the US, the standard of care includes chemotherapy, mostly with ABVD, plus or minus radiation therapy for the treatment of early-stage Hodgkin lymphoma patients. In the mid-2000s, we sort of figured out the prognostic value of interim PET scan. And so as you see here, patients who are treated with 2 initial cycles of chemotherapy and who receive a PET scan, the patients who are PET2 negative have much better outcomes than the patients who are PET2 positive. And so many clinical trials in recent years have been developed around interim PET scan, in which maybe we can de-escalate treatment for patients who are PET2 negative, but then have to escalate treatment for patients who are PET2 positive to rescue these patients given their poor outcomes. Also in recent years, we've been developing novel immuno-oncology agents, including the antibody drug conjugates, brentuximab vedotin, and also the immune checkpoint blockade, nivolumab. And this combination has actually been studied together in the relapse refractory setting with a high overall response rate of 85% and a complete response rate of 67%. The 3-year progression-free survival is 77%. And so this is an exciting new opportunity for us in which maybe we can incorporate brentuximab and nivolumab as a chemotherapy-free strategy into the frontline treatment management of early-stage Hodgkin lymphoma patients. And so the hypothesis of this trial is that the incorporation of immunotherapy combination of brentuximab vedotin and nivolumab will improve progression-free survival and maintain overall survival, while simultaneously minimizing long-term morbidity and treatment-related mortality by reducing exposure to radiotherapy and high cumulative chemotherapy doses. And so here's the study design. We risk stratify patients according to the EORTC criteria of favorable versus unfavorable. If a patient has any one of these following criteria, they are considered unfavorable, which includes age 50 years or greater than 3 nodal sites, which we'll talk about in just a little bit, an ESR greater than 50 if the patient is asymptomatic, and greater than 30 if they have any B symptoms, a maximum thoracic ratio greater than 0.35, and bulky disease, and in this trial, we define that as 10 centimeters or greater. All patients will receive 2 cycles of ABVD initially, followed by an interim PET2, which will be rapidly centrally reviewed. A PET2 negative scan is considered to be a 5-point score 1 to 3, whereas a PET2 positive is 5-point score of 4 or 5. In the patients that are PET2 negative, we call these patients rapid early responders, and the patients that are PET2 positive, these are slow early responders. They will both undergo separate randomizations with the following stratification factors: age, and in the PET2 negative patients, a 5PS score of 1 to 2 versus 3, and the PET2 positive patients, 5PS score of 4 versus 5. In the rapid early responders, the favorable patients, the randomization is the standard of care chemotherapy versus 4 additional cycles of BV-Nivo. For the favorable patients, they will receive only 2 additional cycles of ABVD, and in the unfavorable patients, they will receive 4 additional cycles of AVD as compared to the experimental arm of BV-Nivo for 4 cycles. Notice that all patients who are rapid early responders do not receive any radiotherapy. In the slow early responders, patients will be randomized to receive what's considered standard of care as per the EORTC H10 trial, which is escalated BIACOT for 2 cycles, followed by involved site radiotherapy, versus the experimental arm, which is BV-Nivo for 4 cycles, followed by involved site radiotherapy. And so the primary aims of this trial are to compare the progression-free survival of standard chemotherapy approach versus IO, with the hypothesis that the PFS will be improved in the immuno-oncology arm. There are many secondary aims, just highlight a couple of them for you here. The main secondary aim is to demonstrate non-inferiority of overall survival at 12 years The 12 years was kind of chosen because there's actually no long-term data for long-term survivals of immuno-oncology agents, including BV and also nivolumab. The majority of nivolumab are used in elderly patients with lung cancer, so there really has not been any reported 12-year overall survival, or at least toxicity and patient-reported outcome data at all. There are a number of other secondary aims, including patient-reported outcomes, self-reported late comorbidities as per the St. Jude Lifetime Cohort Study. There are many exploratory aims as well, just point out a few of them to you here. We're actually going to be looking a lot about PET scan, metabolic tumor volume, tumor lesion, total lesion glycolysis, and also seeing if AI can help to predict, to read the PETs instead of a human. There's also racial and ethnic disparities that we're going to be investigating, and also other patient-reported outcomes as well. So just to give you a brief key inclusion and exclusion criteria, this includes ages 5 to 60. The age 5 was chosen as there is no data to support the use of nivolumab in children under the age of 5. An escalated BA-COP is also not tolerated in patients who are older than 60. And so that's why there's a limit of ages 5 to 60. These are newly diagnosed, untreated classical Hodgkin lymphoma with stage 1 or 2 disease. And in terms of functional assessments, they must have adequate heart function with ejection fraction of 50% or greater, a DLCO of 50% or greater predicted. And if they cannot do a PFT, just a pulse oximetry reading of greater than 92% of room air. Key exclusion includes nodular lymphocyte predominant Hodgkin lymphoma, patients with history of active interstitial pneumonitis or interstitial lung disease. Pre-phase steroids are allowable up until the day before cycle 1, day 1. And then anybody with baseline peripheral neuropathy or greater than grade 1 at the time of enrollment, given that patients may be enrolled onto brentuximab. So some of the study takeaways. This is one of the largest studies ever to be conducted in early stage Hodgkin lymphoma. We're anticipating 1,875 patients who are going to be screened, with 1,782 patients eligible for this study. The majority of patients will avoid radiation therapy, as all patients who are PET2 negative will not receive radiation therapy, and this is predicted to be about 85% of the study cohort. Only a minority of patients will receive escalated BA-COP. This is anticipated to be about 7.5% of the entire study cohort, or only 134 patients on this study. And the incorporation of chemo-free strategy in the frontline early stage Hodgkin lymphoma has not been really explored until this point. And so neither brentuximab nor nivo are approved for the treatment of early stage Hodgkin lymphoma in the frontline setting. And so this study activated in April of this year. We've accrued about 50 patients so far, but we're still getting sites on board as well. I can go over, do I have more time? Okay, I'll just quickly go over this part because this is the part of the trial that's led to the most confusion. So how do we count nodal sites? As you can see, one of the unfavorable criteria is if you have greater than 3 nodal sites. And this table in the protocol has caused a little bit of confusion, but essentially we are using the EORTC definition of nodal sites, which is how they define radiation sites to these patients. And so the right supraclavicular and cervical is considered one site, and then you combine the infraclavicular, subpectoral, and axillary as one site. And then the entire mediastinum and hilar areas are considered one site. So just to give you a couple examples here. This is a patient of mine. How you count this would be, this patient has one nodal site for right cervical and supraclavicular, another nodal site for hilar, and another nodal site for left cervical and supraclavicular. So this patient has 3 nodal sites and therefore is considered EORTC favorable. In this patient that looks similar, there's one small difference. This patient has one nodal site that's right cervical supraclavicular, has a high axillary, which would be considered another site, a mediastinal hilar, third site, and then the left side, which is all supraclavicular, which is the 4th site. And so this patient would be considered EORTC unfavorable because he has 4 sites of disease involvement. So we'll go into this. And just to acknowledge the study team here, this is a COG-led study with the PEDS co-chairs of Kara Kelly and Tara Henderson, with the vice chair of Frank Keller, and myself as the adult co-chair. But we have buy-in and support from all NCTN groups. And so, yeah, happy to take any questions if you guys have any.
I have a question. So can you say just a couple of words about the collaborative design of the study? 5 to 60 is the perfect age range as far as I am concerned for AYA and other age groups for Hodgkin's.
Yeah, I mean, so we've it was really sort of based off of S1826.
Yeah.
So there was such a collaborative effort between COG and the children's groups with the adult NCTN groups for S1826. I think, you know, Kara and Tara both truly wanted to this be super collaborative from the beginning. So they essentially involved all of the other adult NCTN groups from the beginning to have buy-in about age and study design from the get-go. So
Fantastic.
yeah.
Thank you so much.
You're welcome.
So next, I will give a brief update on EAQ 202 after his backup slides. Here we go. This is an ECOG Akron-led study that we've discussed here in this committee a year or so ago and subsequently since then. So it's looking at PRO self-reported data in AYAs. So the primary objective is to evaluate feasibility and acceptability of completing PROs for AYAs, and what they have done is to randomize to choice PROs where the young person can choose their own battery of tests to pick the topics that are most appropriate for them versus a fixed PRO. And the exploratory objectives include describing those priorities that are chosen by patients themselves and the trajectories of symptoms during the first months of therapy. And then looking at access to and utilization of psychosocial and financial resources using those PROs to determine what they're needing versus what improvements there might be, and then to summarize preferences for how the PRO data should be shared with the patients themselves and or their providers. So they're looking at a total of 400 patients being enrolled. Again, the intervention arm is a choice of which PRO items they're going to be given, and then the control arm at these various time points, they're just given a fixed set of PROs. 18 to 39s, young adults are the population for this study. They need to be enrolled within 12 weeks of diagnosis and need to have a favorable prognosis type of cancer. The great news is that SWOG accruals have increased from 0 to 43 since our last meeting. So this is wonderful. We're now second in accruals behind ECOG Akron itself. And it's a really nice low site burden study for screening and consenting and registering patients. There is a reimbursement of $1,000 per patient. And then after that, the home institution is done and the study team deploys the PROs via EasyPro, monitors all the follow-up and promotes adherence to the subsequent sets of PROs with texts and emails and phone calls to the patient. So enrolling is the main thing that institutions need to do. Encourage you to participate in that. And any questions you can direct to me or email John Saltzman. Questions on that? Great. Next, we've got Dr. Duvall online to talk about the AYA Sexual Health Survey.
Hi, yeah, sorry I can't join you in person. I'm in Chicago, just not with you. But clinical stuff demands are there. And so next slide, please. I'm talking a little bit about sexual health today in the AYA population specifically. I think we all know, probably who are in the room, that it's a pretty consistent, important concern for AYAs with cancer. And a lot of great work that's already been done, up to 50% of them will actually endorse sexual dysfunction. And this is different than their pediatric counterparts. So if you're diagnosed with pediatric cancer before, puberty and that sexual development, and you're treated and hopefully cured of this, you don't really have persistent sexual dysfunction at rates that are much higher than the norm. But you do in the AYA population. But we really don't know a lot about it. We don't really know how to treat it. Well, we do know some how to treat it, but a lot of the oncologists, we are under-equipped to kind of deal with this really complicated subject matter and sensitive subject matter. Next slide, please. And so some work that was led by Scott Mordler that I helped with looked at, how are we educating our fellows in sexual health and basically in different AYA subdomains, but I'll talk about sexual health specifically. And if you look, over 60% of fellowship programs, this is coming from the fellowships themselves, either have no or minimal sexual health teaching when it comes to AYAs with cancer. And really the trainees at both adult and pediatric programs are very uncomfortable with it. They're either not at all comfortable or they're only slightly comfortable. But all of them endorsed, almost all of them endorsed that it was a very important topic, or it was at least moderately important by all of them. Next slide. So one of the leaders of the Sexual Health Task Force, which is within the SWOG, the Children's Oncology Group, is Natasha Frederick, and she actually polled pediatric oncology providers to figure out kind of where they were at with sexual health communication, their comfort, and some barriers that would be there. And so they did a cross-sectional survey of oncologists and APPs, and they only had about a 26% response rate if you look at individual responders, but they had about 75% of SWOG institutions represented. So it seemed like it was still a pretty representative sample. Go ahead, next slide. And when you look at kind of, and you can forward through a couple more, and if you look at the next, or if you look at kind of what some of their results showed, is that about half, or maybe less than half, thought that the oncologists or the oncology providers shouldn't play a role, or should only play a small role in the treatment of sexual dysfunction and in talking to patients about their sexual health. And if you looked at oncologists, they thought that they should be the primary ones who talk about it. And if you look at APPs, they thought both oncologists and APPs should really be talking to their patients about it. Go ahead, next slide. But if you look at the barriers of it, or if you look at actually what they're talking about, especially when it comes to things that are a little bit more hard to discuss, like sexual orientation, gender identity, sexual function, less than half of these topics are actually being discussed with patients, either never or rarely, or even the vast majority of it are only sometimes, or when the patient asks specifically. Next, go ahead and advance. And there are a lot of different barriers that kind of come up with that. Lack of knowledge is one. Interestingly, they talk about patient discomfort, although if you ask patients, they actually want to talk about it with their oncologist. They're very clear about that. And then the presence of parents or guardians lead to more difficulty too. So the next question is, what are our adult providers doing? Adult providers actually see more AYAs than pediatric providers. So, and theoretically, they might be more comfortable when talking about sexual health, and they might be less likely to have the parent or guardian presence. Go ahead, next slide. So the fearless leader, Becky, was worked with Natasha and actually put together a whole great design. I think she said that she presented to this group at some point a few years ago, and attempted to do it similarly through SWOG, but it just didn't quite work out. But the Alliance, after we had a AYA kind of meeting with Becky present, has a large NCORE network that they regularly poll through emails and with different surveys regarding the Alliance involvement. And with other things that they routinely get response rates about 30% for. So similar to what you would see actually in the response rate that was through the SWOG. And it was very supportive in the Alliance, or supported in the Alliance. Electra Pasquette thought it was a great idea and wanted to get it going. So we had some buy-in, and we were able to push it forward in that setting. So go ahead, next slide. And so we adapted it briefly to adult providers, trying to, get a little bit more comparable to the SWOG data. So looking at those who took care of, 15 to 29-year-olds, which would be more comparable probably to the SWOG side, but then also, including our older AYAs and the 30 to 39-year-olds. Next slide. And so and you can forward through this, sorry. And so, well, we actually have the survey created. It's built. The stats folks are on board. I have a little startup funding, so we'll be able to use the statistician in the Alliance. It's one of the only requirements, which makes it a little bit more difficult. And we're rolling it out in our Alliance meeting in November. So we're doing it with all the in-person QR codes that we can manage, and trying to encourage people at the Alliance and spreading the word to fill out the survey from that standpoint. And that's it for me. Go ahead, next slide. I think that's it.
Thank you so much, Dr. Duvall. Yeah, this will be a great study to get done. It's a really sort of clear and easy follow-on question to the pediatric provider survey, just what's going on in the medical oncology community in the treatment of AYAs. And I had put this through as a seed fund application several years ago, and it was turned down seemingly largely on the basis of the fact that SWOG didn't want to overburden its membership with surveys. And so that's a hard thing to get around, given that it is a survey. And, and pretty much we wanted to keep it fairly intact in order to be comparable with the pediatric population. And so it is nice that we have the NCTN working group specific to AYAs kind of back in action after the pandemic, which allowed us to share this information with the Alliance and get it up and running there. So that'll be exciting to get this data. Thanks, Adam. Any questions for him? Yes.
Thank you. It's been great for everything, but do you have a paper or something that we can get the contacts of all the people? So if we wanted to join the studies, we could, because I took a picture of what you had, but we're trying to, or should we just get it through the study number if we wanted to go ahead and do that?
To enroll in this survey.
To enroll in this study or the other studies that were presented?
The other studies are mostly NCTN studies, and so you could email me with any questions, or they should be online in terms of who the leaders are of the study, but I'm happy to help with that. This one, I believe, Dr. Duvall, you've got going out only through the Alliance, correct?
Yeah, it's only through the Alliance. I mean, I think we like you said, Becky, we're limited because they were told us not to spam their folks. So
yeah.
So I don't know that. I mean, I'm happy to send it to you individually. We're just we're going to pool the data. So the more the merrier, really. But yeah, I think it's only going to be organized through the Alliance, at least. I mean, it's just a survey question, so it's easily emailed out. But so if there's opportunity potentially to email it out to other listers, that'd be great. But for now, it's only going through the Alliance.
Okay, we'll give you our information before we leave. Thank you so much.
Fantastic. Thank you. All right. Thanks, Dr. Duvall. And next up, we've got Allison Rosen and Melissa Boschman talking about the NCORE pilot grant.
Yes. Hi, everyone. I'm sorry I can't join you in person this evening, but we're just going to provide a very brief update on our NCORE pilot study that's supported through the Hope Foundation, where we're trying to develop tailored AYA trial messaging to improve understanding around clinical trials. And this is our study team. Next slide, please.
It's not yours.
So, oh, sorry.
Not yours. You're good.
Oh, okay. So the goal of this study is to design an intervention that's focused on increasing clinical trial enrollment among AYA groups, particularly those who are underrepresented in trials. And so to do this, first, we've been partnering with our SWOG and SWOG AYA advocates. Allison's she's part of our team, and she's gonna talk next. And the goal is really to identify 2 to 3 high priority topics that AYAs feel are potential concerns around clinical trial enrollment. And to date, we just conducted our 5th focus group earlier this week and are working on analyzing the data. Next slide, please. After that, our plan is to co-design and co-develop messages and materials that are targeting these high priority areas, and then finally to select and evaluate social media platforms and channels used to disseminate messages to really see what our reach can be among this population. Next slide, please. So this is just a quick slide that shows you the demographics of our focus group participants. You can see so the fifth one obviously is not there, but we did have 5 participants who also would be added to this list. The mean age was 33.5 years old. Most in this were female. However, in our most recent focus group, we specifically recruited males, and so all of the participants were male. We had 25 participants who identified as Black. Most who identified from or who said that they were from urban areas. However, a quarter were from rural areas. We were really trying to have a representation. And then you can see that the cancer types there. Next slide, please. And so we based our focus group interview guide on a recent publication by Abreu et al., where they really identified these 3 key topics that were important potential barriers to clinical trial enrollment among AYAs. And so we really tried to probe on these topics and understand more, and specifically understand what messaging might be accessible and important and helpful to AYAs when thinking about clinical trials. And now I'm going to pass it over to Allison.
Okay, thank you. So here's some of the key quotes that we pulled, and a lot of these quotes were similar for all of the participants. So when we talk about information, a lot of people said they thought or were under the assumption that clinical trials were a last ditch effort. So that's something we definitely want to target when we're doing messages via social media, to explain really what a clinical trial is, and that it is not a last ditch effort. People would have loved to have seen statistics and more information when they were given information about clinical trials, or people were trying to explain information about clinical trials. And then psychosocial, there's a lot of, again, we go back with the last ditch effort. They think I'm going to die, and they have in their mind skepticism, suspicions, especially minorities, because of historical treatment. And again, last resort, you see that in the psychosocial. So really making sure when we are doing some of these social media messages that we include the populations that we're trying to represent. So it shouldn't be a white woman that's giving these messages out. It should be people of specific races, minorities, sexes, so that they see someone like them talking to them about clinical trials. And then financial, I think at one point before I had the knowledge that I do, I thought it would cost a lot of money to leave your state, to go stay in a hotel, to enroll in a clinical trial. And so the financial burden that we heard from a lot of people were misconceptions that they had, that they wouldn't have the money to participate in a clinical trial. They would go bankrupt. They couldn't work. And then you have specific things surrounding family. They didn't want to leave their family. Would they have to pay for a hotel? How would they, leave work? All valid things for patients to say. And this is just some of the information. We're taking everything from all the trials and putting it together and creating key themes, like you saw a lot on the last slide, but we're doing that now, incorporating all the males that we had that participated too, because that's a really important voice. Now, if you all will get your phone out, I'm hoping this will work. We have a lovely QR code on the screen. Let me know if it works. Yeah, did it work? Yes. Okay, please, we want you all to help. We're going to ask, obviously, AYAs some of these questions, but we also want you all to answer these questions regarding platforms as we move forward with figuring out where we're going to target, who we're going to target. So you want to know sort of where you go and who you are as far as who's in this room. So I'll give you a minute or so to fill that out. Just, I think, 5 or so questions. Everyone have the QR code working?
Yeah.
Okay. So as you're filling that out, I'm just going to continue on because I know we have a packed program. The next steps are continue to meet. We meet bi-weekly, the advocates and the Columbia team. We're going to finish analyzing all the focus group information that we have, and everything's going to be in these 3 main categories: informational, psychosocial, and financial. We're going to do an in-depth review of the literature just to make sure we're not recreating anything that's already exists, and make sure it follows along with the literature, and we incorporate that in what we're going to be creating. I think a big thing that maybe hasn't been done, or I haven't seen necessarily done, is an in-depth social media content analysis. So we're going to look at Twitter, Facebook, Instagram, TikTok, to see what's been done, what existing videos are out there, how well they have done, who is the audience, who is actually giving the information out, what type of themes and hashtags they're using, and then how they're delivering that message, because it's going to be different with, Instagram, Facebook, and TikTok. You might have some dances, then you might have some reels, you might have some just pointing, you might have just information on the screen, you might have some people actually talking and telling their stories. So we really want to see what's been out there and what's been popular, and we want to make sure we're using those same type of platforms and same type of content. And the focus group participants that have participated so far are going to continue to help us. So it's not just a view of us advocates that are on the planning for this. We're going to include people that have been very, very vocal in the focus group. And this is the amazing group that we're working with to make all this work happen. And we thank you. And if anyone wants to get more involved with this, please let me know. We would love to have you, especially as we're moving into creating the content and trying to disseminate it and implement it to the best of our ability to get more people information, not misinformation, the right information about clinical trials.
Awesome. Thank you, Allison and Melissa, and we'll all look forward to the results of our responses at the next meeting. I'm glad that the link worked. That was cool. All right. Next, I am pleased to introduce Dr. Erin Roche, the new liaison to the breast committee, from the breast committee to the AYA committee. She's a breast oncologist at the Cleveland Clinic, and she's going to discuss some of her recent interests so that we can all get to know her. Yeah, it just advances like that in this back. It's just like that.
Yeah. All right, great. Thank you, Becky. I really appreciate the opportunity to speak with you all. So as Becky mentioned, my name is Erin Rush. I am a breast medical oncologist at Cleveland Clinic in Cleveland, Ohio. And I'm again honored to have the position as the breast AYA liaison. And so to begin, and again, this is more of an introduction of myself and what some of my interests and work has been or has entailed since I've started at the clinic. And so I'll focus on what we have been working on with one of my surgical colleagues, development of a young women with breast cancer program at CCF. Young women diagnosed with breast cancer, we know, have a unique set of needs based on their life stage at the time of their diagnosis. The Cleveland Clinic and Breast Cancer Program, like many others, provide a number of clinical and support services for our young adult breast cancer patients. However, not all services are provided at all of our sites, as we at the clinic have a lot of regional colleagues that aren't at main campus, for example, and not all patients are also made aware of our offerings. So we know there are opportunities to enhance some of these offerings for our patient population. For the purposes of our program, we designed it with for women diagnosed with breast cancer up to the age of 45, regardless of stage, those who were diagnosed or treated at Cleveland Clinic, and following these women through diagnosis or at time of diagnosis through survivorship. Our vision is that every young adult with breast cancer cared for by the Cleveland Clinic has knowledge of and access to all clinical and support services that might benefit them through their patient experience. When we started out on this project of developing this program, we gave ourselves a set of objectives, some of which I've listed here. So first, to identify these clinical and supportive services that are available to our young breast cancer patients at Cleveland Clinic, to create a mechanism to ensure that all young adults with breast cancer have access to these services, to enhance and develop unique and complementary service offerings for our young breast cancer patients. Importantly, to develop opportunities for young women to participate in research. And then what I'll highlight here a bit more is our care paths, which at Cleveland Clinic we design as physicians, as providers. And the goal of these care paths that are made based on things like NCCN guidelines, updated presentations at meetings, et cetera, is really to ensure that treating physicians within Cleveland Clinic are providing evidence-based guidelines to ensure that all patients, regardless of where they're being treated, whatever CCF location they're at, that they're receiving the same care.
And then also importantly, and we've done some of this as well to date, educating our providers on these care paths and creating really a core group of physicians and providers specialized to provide this multidisciplinary care. Here are some of our accomplishments to date. So we have defined our program and we've identified these clinical and supportive services for patients. We've identified champions within these multidisciplinary subspecialties. So one of my surgical colleagues and myself have primarily been responsible for the care paths, medical oncology, radiation oncology, and then we've also established a very collaborative relationship with one of our maternal fetal medicine colleagues. The care paths that we have published to date include one for young women diagnosed with breast cancer, and then also a pregnancy-associated breast cancer care path. And then currently we're working on a consensus manuscript for pregnancy-associated breast cancer. The next couple of slides, and I know the print is very small, but these are our two care paths, the young women with breast cancer and then the pregnancy-associated on the next slide. And again, I'd be happy to share these and or discuss offline. But I've highlighted some of the unique aspects of these care paths for our patients. So you can see to the very left, at the time of initial consultation, in addition to meeting with us as medical oncologists, surgeons, radiation oncologists, it's important for these patients to be meeting with genetics, having that oncofertility discussion, and then an REI referral if appropriate or indicated. We also mentioned that, as Dr. Moorhead mentioned earlier, the option of utilizing a GnRH analog for ovarian protection for our patients, in addition to standard fertility preservation methods, if they are interested. And then we also, we know that for our young women diagnosed with breast cancer, particularly those with ER-positive breast cancer who are at high risk for recurrence, that there's data showing a benefit with utilization of ovarian function suppression with endocrine therapy. And so this is something also that we call out in this care path. In the survivorship setting, again, this is not a restrictive list, but important to address psychosocial concerns, sexual health, bone density, fertility, contraception. And then we saw late last year the results of the positive trial for those women with ER-positive breast cancer receiving endocrine therapy to discuss the potential for interruption of the endocrine therapy for attempts at conceiving if deemed appropriate. And then here's our pregnancy-associated breast cancer care path. Again, highlighting some of the unique aspects of care. We talk about relevant staging studies that can and cannot be done during pregnancy. We discuss chemotherapy timing during pregnancy, guidance regarding specific regimens, and supportive care agents. We do call out the avoidance of blue dye and radiation during pregnancy. We discuss, and our maternal fetal medicine colleague added to this with monitoring of fetal heart tones, fetal growth during receipt of chemotherapy, fetal echo if the chemo is cardiotoxic. And then we know that timing is critical, or the management of breast cancer during pregnancy. When considering timing, it's very important, and that fetal delivery should be planned. And the timing should consider growth, development, and then importantly, decreasing the risk of myelosuppression if the patient's receiving chemotherapy. And then post-delivery issues, again, including but not limited to contraception, breastfeeding. Breast cancer in AYA patients. So breast cancer is the most common type among AYAs of age 15 to 39 years at diagnosis, accounts for 30% of cancers among AYA women. The incidence of breast cancer is rising among young women, and we see that AYAs are more likely to present with a more advanced stage and with more aggressive tumors compared to older women. AYAs are also more likely to experience side effects from treatment, both physical and psychosocial, much of which has been discussed in the session today. And then, as I've mentioned, unique issues are identified in our AYA young breast cancer patients, and multidisciplinary care is key. And so I think there's multiple opportunities that could exist for collaboration between our AYA and breast committees here within SWOG. Potential utilization of a retrospective database from completed trials to answer some of the questions that we find intriguing. Oncofertility is a very integral component of our care for our breast cancer patients and within the AYA community. So I think that research questions could certainly stem from this concept. I have a particular interest in ovarian suppression. It's something that we're using a lot more frequently for our breast cancer patients. And I think there's definitely important questions that still remain here, a couple of which I've listed here, one of which is the dosing schedule of the specific GnRH analog that we're using. The breast cancer data for ovarian suppression in terms of treatment utilizes monthly formulation. But we do have some retrospective data that suggests that every 3-month goserelin provided more effective ovarian function suppression compared to monthly. I think another question is how often and how best to monitor hormone levels to ensure adequate OFS. Pregnancy, contraception, I think are also key issues within this patient population. I not uncommonly have, a gynecology colleague reach out to me and ask about a specific contraceptive method for a patient with a history of breast cancer. So I think it'd be interesting to look at current practice patterns and how this might differ in terms of the specific phenotype of breast cancer, meaning ER negative versus ER positive. And then a note on the electronic medical record. I think some of my prior work at UCSD before coming to the clinic, I was involved with dissemination implementation research. And when I was at UCSD, we looked at improving the fertility referral process within our institution, utilizing a DNI type approach where we interviewed providers and really tried to assess barriers and then ways for really affecting change and educating providers and disseminating this information. And then lastly, I'd just like to highlight an energy trial, BR009, that SWOG is participating in. This is a phase 3 study, an adjuvant trial looking at the addition of adjuvant chemotherapy to ovarian function suppression plus endocrine therapy in premenopausal patients with ER positive, HER2 negative breast cancer and an oncotype recurrence score of less than or equal to 25, the offset trial. We know from data from both the TAILORx and RxPonder trial in breast cancer that that postmenopausal patients with ER positive, HER2 negative breast cancer with either no lymph node involvement or limited lymph node involvement and a recurrence score up to and including 25 did not seem to benefit from the addition of chemotherapy to endocrine therapy. However, in both of these trials, there was a signal of benefit for premenopausal patients. And so one of the questions, an important question that has stemmed from this is the benefit that we're seeing due to the cytotoxic chemotherapy, or is it due to perhaps the ovarian suppression effect of chemotherapy? And so this trial is designed to answer that question. And you can see here the eligibility criteria: premenopausal patients with resected ER positive, HER2 negative breast cancer, either no lymph node involvement with a recurrence score 21 to 25, or 16 to 20 in any high clinical risk feature, which is listed there on the right, or patients with 1 to 3 lymph nodes involved and a recurrence score up to and including 25. And then, as I mentioned, patients will be randomized to either ovarian function suppression plus an AI or chemotherapy plus OFS plus an AI, with the primary objective of invasive breast cancer-free survival. So I bring this trial up just to highlight, I think this is another kind of potential collaborative effort where, again, our two committees could discuss some ways to work together and think about some important questions to answer for this patient population. Thank you very much, and happy to take any questions.
Thanks, Dr. Rush. And if anyone has a research interest in those cross-cutting topics that she mentioned, please either reach out to her or me, and we can talk and perhaps plan some future studies. And this last one that you mentioned is a really important question to answer. And it's nice to see an AYA-specific trial arising anywhere in SWOG, and it's great from the breast committee. So looking forward to working with you.
Great. Thanks, Becky. Thank you.
And then we have saved the best for last. We have our guest speaker, Dr. Alicia Alvarez from UC Davis, and she will be discussing the global burden of AYA cancer with a focus on Latin America. And I'm pleased to see we have some people from the Latin America Initiative have joined us, and we appreciate you attending and are looking forward to discussion.
Hi, thank you so much for having me. So I'm actually a pediatric oncologist. I appreciate you letting me into the meeting. And so I have nothing to disclose, and this is going to be a bit of a different talk in that I'm not going to be talking about any drug trials. So cancer in AYAs is a global problem. There are approximately 1.2 million AYAs diagnosed with cancer each year, and over 80% live in low and middle income countries. And I just wanted to take a moment to express that not all AYA age definitions are equal. I know you're very aware that in the United States, we use 15 to 39 as defined by the NCI, and actually the European societies have adopted a similar age range. But with regards to the upper age range, this is a bit controversial throughout the world, with some age ranges being 24, 25, even 21 in some countries. And so we chose 15 to 39 to be the most inclusive possible so that we could compare across different studies. And this is the title of our study. It's in Lancet Oncology last year, if anybody wants to look at it for further detail. And so what is GBD, or the global burden of disease? This is out of the Institute of Health Metrics and Evaluation out of the University of Washington. And it's built on the premise that everyone deserves to live a long life in full health. And we need health metrics that are comprehensive and comparable in order to do this. And so it's a systematic effort that allows for comparison across diseases. And there's over 300 diseases estimated. And this allows for comparison, as our interest is in cancer, to other diseases around the world. And we couldn't do this without the collaborator network, which I just want to highlight involves over 5,000 collaborators across 150 countries and territories. And each of you are invited to be a collaborator as well. And so why do we need this study? Well, not every country has a national registry. In red, we see countries without any registry, and data can be incomplete. And so GBD is the only global disease burden estimation framework that takes into account disability adjusted life years and provides global disease burden estimates across time. And so the goal of this study, this was the first adolescent and young adult focused global burden of disease cancer study. And so we want to estimate the global burden of AYA cancer with a focus on disability adjusted life years to inform global cancer control measures in this unique age group. This study is also used by the World Health Organizations, different health ministries, and also the Bill and Melinda Gates Foundation. And so the study I'm talking about is from 2019. And so we'd have estimates for global, regional, and national for 204 countries and territories. Again, we use 15 to 39, and we did estimates for male, female, and both sexes combined with 32 cancer causes. And we also divided areas of the world by socio-demographic index, which is similar to what some people are more familiar with low and middle income countries and high income countries. And it's a composite measure of income, fertility rate, and average educational fulfillment. And we report this in quintiles. And so here, just briefly, are the cancer causes. This is the wording that is used by the Global Burden of Disease study. And we excluded non-melanoma skin cancer. And so the way that they obtain the data is through cancer registration systems, vital registration systems, and then verbal autopsies. For those who are not familiar, that's actually going door to door in some countries to identify what was a potential cause of mortality. And then through this, they estimate incidence, mortality, prevalence, years of life lost, years lived with disability, and disability adjusted life years. I'm just going to highlight the disability adjusted life years for a minute because I know it's not a concept we're necessarily all familiar with. So disability adjusted life years essentially equals years of life lost plus years lived with disability. One DALY equals the loss of 1 year of full health. And so just in a different way to visualize this, this is potentially a patient with cancer who was born. In gray has healthy life. In orange, it's the disease, like the life lived with disease or disability. And so you can see a diagnosis of cancer and then cardiomyopathy and then death due to cancer. And then we have the expected life years. And so the years of life lost are the time from death from cancer to expected life years, plus the years lived with disability equals DALYs. And so here are some of our study results. And so we can see here, we have the estimates globally and by SDI quintile. And so close to 1.2 million adolescents and young adults are diagnosed with cancer each year globally. We have 396,000 that die of their disease and 23.5 million disability adjusted life years that are attributed to cancer in this population. And in this population, 97.3% of the DALYs are due to years of life lost and 2.7% are from years lived with disability. And so here we have a map of DALY rates by age standardized quintiles. And so here we have regions of the world, and the highest burden is in red and the lowest burden is in blue. And so you can see the highest burden of DALYs is in some areas of sub-Saharan Africa, Asia, and some areas in South America. And this looks similar to children for high income countries and similar to adults for lower middle income countries. And so here we have on the left, there's ages 0 to 14, and then on the right, ages greater than 40, and then middle, adolescents and young adults, so 15 to 39. And we have the different coloring due to the cancer causes. And so this is for 2019, and it's cancer types by age group and both sexes combined. And one thing I want to highlight here is that you can see that a proportion of DALYs due to leukemia is higher in the lower age range, whereas if you get up to the higher age range, there's more DALYs attributed to carcinomas. And then here, this is just to highlight, again, we have age-specific DALY rates for both sexes combined, and the rates were expressed per 100,000 person years. And you can just, as you imagine, cancer incidence increases with age. So here, the proportion due to DALYs, the proportion of cancer attributed DALYs is highest within the 35 to 39-year-olds. Then here, I think this is interesting. It's looking at DALY burden by sociodemographic index. So on the left, we have high sociodemographic index, and on the right, we have the lowest. And so a couple of things I think are notable is that one, looking at cervical cancer, you can see the proportion of DALYs attributed to cervical cancer actually increases as you go to the lower sociodemographic index. I think there's various reasons for this, potentially cervical cancer screening and HPV vaccination. One of the other things is that brain and CNS cancer, the proportion is lower as you go into the lower sociodemographic index areas of the world. And we've postulated, I'm not sure if this is entirely true, that there's less of these cancers, or if it's just that they're not being diagnosed and therefore we're not picking it up. And then in gray, we have our unknown or other malignant neoplasms. We know that the patient died of cancer, but we don't know the actual cause. And you can see that the proportion of this is highest in lower middle income countries where maybe we don't have as many cancer registries. And so I think this is one of the biggest things that came out of this study is that often when we think of global diseases impacting adolescents and young adults globally, we think often, I think, of more communicable diseases and less about cancer. So this is the first time that cancer has been compared to communicable diseases within this framework. And so you can see that cancer is the fourth leading cause of death globally. And it's ranking, it's low, as you're in high middle income countries, it's ranked higher, and this goes down as you go into low and lower middle income countries. And then we also wanted to look at the burden. And so it's in the top 10 for the burden of disease globally as impacting adolescents and young adults. And you can see the burden is higher in high income countries and lower and low middle income countries as you look at more other communicable and non-communicable diseases. And so in summary, adolescent and young adult cancer contributes substantially to the overall disease burden in adolescents and young adults. And I don't think this really had been shown comparatively before to other diseases. And so I think this provides new insights into the distribution and magnitude of the problem and the cancer burden. And this can be used to inform country level cancer control efforts. And I just have to say, I started having an interest in adolescents and young adults globally during my fellowship, and over the past 10 years have really seen an interest in this age group really take off, not just within the US, but within the global context. And so next steps, we're doing estimates for 2021 that actually just came out, I think 2 days ago. And we're looking at new cancer causes. So we're actually including sarcomas, bone cancers, things that really impact the AYA age range that were left out before because this group was not necessarily a focus of this study. And then we're also looking at trends over time. And so I will be writing that paper and hopefully you can look forward to seeing it in the next year. And so I just wanted to I was asked to talk for a few minutes about a project that I started in fellowship. It just started with a question of where adolescents and young adults treated in Latin America. My family's from Mexico City. This was a question that came up when I was visiting my aunt who was undergoing treatment. And from that, like with any question, I asked if I could start with a survey and then went from there. And it's a group effort in that my dad made this logo. So I just have to say that. So AYA cancer in Latin America. Latin America is a region that has made major strides in development in healthcare and cancer control programs. And many Latin American countries even have specialized pediatric cancer programs. But I think there's some gaps that remain. And one of them was who treats adolescents and young adults with cancer. This was really a question that came up from a lot of the providers in these countries that I have worked with closely and how I could help answer these questions for them and where are they treated. And so we wanted to characterize the oncology physician workforce in cancer centers potentially available to treat adolescents and young adults with cancer and to understand the barriers and facilitators to providing and improving care for these patients. And so like I said, we started with a survey and then moved on to interviews and now focus groups. And so these are our project participants. I actually started with a pediatric oncology group out of Central America. That is similar to like the Children's Oncology Group, but for Central America, and then participants from Mexico. But as more people heard about the project, we started including other countries within South America. I wasn't trying to be exclusive. It was just more, I didn't think anybody would be really interested in my small project. And so this is a survey. This survey, it was one of the first things that I did, and it was with pediatric oncologists within Central America and Mexico. And so we really wanted to find out what was the maximum age and years of patients with cancer treated at your institution. And so we found the majority treat up to age 18. But one of the things that we found is a lot of these physicians were not actually comfortable with treating anyone higher than what they were allowed to treat. And then we also wanted to find out what dictates the maximum age at your institution, just thinking further about interventions and how potentially to collaborate. And so one of the things we were finding is that the majority is by the department or division, but there's also a large proportion that's due to the government. And then we found that in the majority of cases, over 70%, patients were actually allowed to stay at the institution. Say if the cutoff at the institution was 18, they started treatment at 17, and we're still getting treatment at 18, they could stay, but at about 30%, they actually had to leave and go to the adult institution. And so you can imagine that's where a lot of sometimes the falling in between the cracks happens for this population. And about 70% of pediatric physicians said they have collaborated at some point with their adult colleagues. So that was helpful to know. And so then we did interviews with physicians, and this was at the beginning of the project. So it was in Central America and Mexico. And we interviewed one pediatric oncologist, and one adult oncologist in each country. And so I'm not going to read all of it just given time, but we found that a lot of the barriers were the discontinuity of care that I mentioned, missing collaboration between healthcare teams, abandonment of therapy, treatment costs, delays in diagnosis, competing resources, and lack of psychosocial support and services. And I just want to point out, this is a lot of what we have in the quote unquote high income countries too. So we also then wanted to interview people, our non-physician stakeholders. So social workers, dietitian, psychologists, nurses, other people taking care, doing really important work with adolescents and young adults, and foundation leaders, which are, they have a very important role within Latin America in paying for a lot of the treatment that these patients get. And so we also wanted to focus on strategies to improving care. So a lot of people wanted AY-specific treatment sites, patient advocacy, increased social support, more dedicated resources and staff, increased funding and education for patients. And a lot of the barriers that they faced and thought of were the same as the physicians. And then obviously within those groups, we were missing the voice of the patients themselves. And so we did something that I did not think was going to work, but it actually did. We have focus groups. We've completed 8 focus groups with survivors from 7 countries, run by a sociologist who's from El Salvador, but currently lives in the Netherlands over Zoom, and somehow it worked. And we had 24 participants. And I think these are really poignant, so I'm going to take a minute to read them, but these are some of the themes that have come up. We're still analyzing it, but the hospital becomes your second home. It's your second home because they gave you all the comforts. They gave you a television and you were never bored. It was good, but there were times we needed to feel the motivation of friends. I had to miss school for about 6 months due to chemotherapy sessions. I went back to school and they told me I had to retake the year. So it was very hard for me. I felt that due to the illness, I was falling behind at school. I'd never retaken a year. So I felt terrible. I felt like I was failing. We never had psychological help after treatment. At least I never had. A little psychological help after the treatment would not hurt. How to overcome things. It's difficult because we started very young and we had no idea what life is or how to live. And they literally cut off your time, our youth, to fight against death, literally. And after overcoming, it's like now you have a life to live, go live it. But it's already marked you and it's difficult to rebuild your life after what you have lived. And so we took all this information, and one of the things that the physicians had asked for was actual recommendations that could be published or guiding principles for the care of adolescents and young adults that they could then take to their hospitals or health ministries to help improve care for this patient population. And we did not focus on treatment, but more the areas that they brought up as barriers to care. And so with the literature review, our interviews and our surveys, we came up with 18 proposed statements. We sent this out to 25 experts, and this is modified Delphi methodology. We had 25 expert participants from 15 countries, 12 of the countries from Latin America, and included adult and pediatric oncologists. It went through 3 rounds, and we ended up with 21 endorsed statements. And I won't read you all these statements, but the majority of our statements included clinical care, and then we had supportive services, education for physicians, and advocacy. And just touching again upon these age cutoffs. And for this, we defined adolescent and young adults as 15 to 29, just to make it more relevant to the countries we're working in. But if an AY patient 15 to 29-year-old is treated as an adult institution and or by an adult oncologist or hematologist provider for a cancer diagnosis that is more common in children than adults, a pediatric oncologist or hematologist should be consulted to help establish a treatment plan. So that's just one example. And so in summary, you can see there's age limits, restricted exposure given the age limits, and experience among providers that might limit the ability of AY specific services and may limit comprehensive care of these patients. And our goal is to expand the understanding of clinical and psychosocial barriers and facilitators to identify areas for potential intervention. And I think this really requires a health system approach, as you can see from various places. It's at the hospital level or government level that dictates these age ranges. And so we're expanding our current study to the rest of South America is our goal. And we want to work on developing clinical models of adolescent and young adult care. Again, this has come from the physicians from each country. I have what I call a physician champion that has worked with me since I was a fellow and has helped recruit other providers and patients for this work. And again, this is something they had asked for, is to help figure out how to collaborate between pediatric and adult colleagues. And also we're going to be working on identifying what are key components for a potential AYA program within these settings and what's feasible and what measures should be implemented. And so for the Global Burden of Disease study, these are the people I'd like to thank. And then for Playa, the physician champions from each country from which these ideas have really come from in collaboration, our research participants, and then the American Society of Clinical Oncology for taking a chance on this work and funding it, and Keaton's Child Cancer Alliance. And then if you're interested in becoming a GBD collaborator, you could just Google it, or here's the website. It's a pretty simple process. They ask for your areas of expertise. They ask for your a resume. And then anytime a paper is written or published or is going to be published, they send it out to the collaborator network and ask for your comments. And if you give substantive comments, you can be included as an author. For the AYA paper, for example, I had 5,000 individual comments that I read through. So I just think that that speaks to how interested people are in this topic and how much they want to help this population of patients. Thank you.
Fantastic. Thank you so much. I know that the Latin America initiative at the last meeting had pulled some similar data from the Latin American countries and found some similar things, like cervical cancer is, more impactful there than in the States, et cetera. Does somebody want to touch on that and then address any questions or any thoughts that come up having heard Dr. Alvarez's talk?
Hi, everyone. I'm Javi from Chile. I think most sites in Latin America face the same problem, that we want to have this data, the national tumor data, but we're not really sure how we are going to address that issue. In some sites, in some countries, we have one person that is in charge uploading the information. Other countries has some more standardized approach, but in the end, we are not sure if maybe we should focus on some cancers, some specific cancers, in order to know if we are really having good data, because in the end, we don't audit that data. And so my question, having said that, my question was, if this approach includes some kind of semi-structured interviews or something that can put the value of the discovery in the patients and participants as well. Not only the experts, but also the people who is having the cancer.
Yeah. So as far as the research that I'm doing, we have the patients. And so as part of our next steps, we're actually going to convene not just a panel with physicians, but we're actually going to convene a stakeholder group with a core group that's going to involve patients themselves, caregivers, and many other people, not just the doctors. I have to say it was probably my naive approach as a fellow, and also with the people that I had contact with in the beginning. And then as to the registry, we can talk about it more later, but actually SWOG, which is the Pediatric Latin America Society out of the International Pediatric Oncology Society, they're discussing how to do the same thing and how to put these registries together and potentially focus on some AYA-specific cancers. So that might be an area for collaboration moving forward.
Hello. Nice presentation. Just to comment that in our institution, that is the Institución Nacional de Enfermedades Neoplásicas, NCI from Peru, we have a oncology service for young adolescents. The service have 25 years, almost more than 25 years. is an important program into the institute because the whole population is concentrated in one model that is supporting with the whole way that you present. Or before, is similar to breast cancer program to that present before. I think that is a good opportunity to connect the programs to, because we have a hospitality registry at the institute, and we have to the national registry, the Lima Metropolitan Registry, that the information is there, and we're happy to collaborate.
Thank you so much.
Other comments, questions for Dr. Alvarez? All right. Oh, yes.
Quick question about the registry. Are you working with GlobalCan or is this completely separate from like the GlobalCan registry?
It's separate. So
Okay.
there's GlobalCon, IARC, and GBD are the three main studies that determine the global burden of disease. But the other studies focus more on incidence, prevalence, mortality, whereas the global burden of disease study is the only one to estimate this disability adjusted life years. And given that we have a population of patients, specifically within adolescents and young adults, who have a long potential life expectancy, this study is focusing on that more, just to see what the projected life lost is, which I think a lot of health ministries and governments are interested in, because this is a very productive age, contributing to society. So.
What is the level of confidence with the data, given that sometimes you're needing to knock on people's doors?
Yeah, that's like the minority of the data, but it's a good question. There's a lot of estimations that are done by people much smarter than me. They've been doing this for many years. And so at the GBD, at the IHME, they're pretty confident about their data. And each year is, there's an iterative approach. So each year more data is contributed by collaborators, and it's checked and it's redone. So it's not just added, it's redone completely to make sure that it's as accurate as possible. So.
Nice. And is there any mechanism to add in particular clinical questions to what is collected? Like how often is young adult breast cancer diagnosed at stage 4, that type of thing?
Yeah, it's pretty high level, but they are trying. St. Jude collaborated with them a few years ago to actually fund adding pediatric and adolescent young adult cancer causes. So we are working on that. There's actually risk factors that we're going to be adding into this AYA upcoming paper, but staging is pretty difficult when registry data is limited, but I think it's something to continue to work on.
Cool. All right. Thanks everyone so much for attending. And thanks again, Dr. Alvarez, for joining us tonight.
Thank you for inviting me.
Have a good evening.